Oh, boy. Good to see you again, and let us continue moving on this particular subject of applied toxicology. Uh, in the last presentation, we were talking about the wildlife toxicology, and this time the subject is very much relevant to man, and that is clinical toxicology. Clinical toxicology is very close to medical toxicology. Clinical toxicology is very close to uh, what you talk forensic toxicology. These two subjects are very much close to clinical toxicology. In clinical toxicology, we deal with accidental, deliberate, or such type of mass poisonings that occur due to a chemical. That chemical may be a gas, that chemical may be a liquid, that chemical may be a drug, it can be a pesticide, so on. It's a large list of chemicals which can be used as poisons. Man has been using poisons to kill the enemy. Man has been using poison to kill himself, and when he uses a poison to kill himself, it becomes a deliberate poisoning. And when the poisoning occurs in an occupational or industrial environment, it becomes a accidental poisoning, as it has happened in Bhopal gas tragedy. It has happened in Chernobyl. It has happened in many other industrial setups. From your background. When we study this science of clinical toxicology, it involves a few components. And those components are that you imagine a situation in which a patient is brought to an emergency ward of a hospital. So, what a doctor is going to do with the patient, knowingly that he or she has taken a poison, then what she is supposed to do, what a doctor is supposed to do. She must have a very good knowledge of toxicology. They must have a very good knowledge of forensic toxicology, and as a rule, they should know about the a little of the biochemical effects of toxicology. So, when a patient is brought to the hospital, the first thing that a clinical toxicologist performs is the stabilization of the patient. The patient is to be stabilized because the patient is under the stress, patient is under trauma, and the patient is to be stabilized. How he can be stabilized? By oxygenation, by ventilation. These are some of the first aid steps that if the patient needs oxygen, if the oxygen is to be given, if he or she is to be put on ventilation, the ventilation arrangement is to be done. So first it is the stabilization of the patient. The next step that involves in this is uh, the what you talk is the evaluation of the patient. Then the doctor needs to evaluate the patient. How he is going to evaluate? There are some simple clinical observations which are to be made. They deal with the blood pressure, they deal with the pulse rate, they deal with temperature, they deal with the status of the pupil, they deal with the consciousness, they deal with the other symptoms of hyperactivity, if any. So these observations are to be made first. After stabilization, these are some of the observations which a clinical toxicologist will make. A team is there including the information center of toxicology and the physician and the medical toxicologist. Then the next thing that the doctor is going to do is to know the history of the patient. Generally, the patient is not in a position to tell what he has taken. He or she is unconscious, and she is not able to tell what has actually been done. So it's very difficult to get this information from the patient, but the family of the patient or the friends of the patient or whosoever has brought to the hospital, they may tell us about the history of the poisoning, what type of chemical has been ingested, or whether it has been ingested or inhaled or through some other route. So that history must be known to the doctor, to the team who is attending this. Then it needs the psychological assessment. It needs the dose, if it is possible, then what type of or how much amount of the poison has been taken up by the patient. Then after history, if the patient is able to tell that he or she has taken a dye, or the patient is able to tell he has consumed lot of cyanide, or he has consumed lot of copper, or he has consumed lot of mercury. If such type of information can be obtained from the patient, fine, or from the family or friends of the patient, fine. And if it is not, then it becomes very difficult for the clinical toxicologist to study further. So what can be done? There are some simple tests that need to be done. It is called as diagnosis. First is stabilization, second is the history, third is the diagnosis. That is the laboratory diagnosis. In laboratory diagnosis, the pulse and blood pressure and everything that you have already done. But now you need to know certain things more about. At present, we have got very good clinical analytical instruments. Immediately, a blood sample is taken and given to a person to a GLC or HPLC lab, but it analyzes what it is. It's very easy now. But in good old days, there used to be some methods to determine the diagnosis, and that was one very important thing that comes in literature is the anion gap. Anion gap is the difference or the ratio between this serum or the blood concentration of sodium and blood concentration of chloride and bicarbonates. This is called as anion gap. And there is another parameter of diagnosis that is called as osmol gap. Anion gap should be less than 12 units. And osmol gap is the estimation of sodium, glucose, and blood urea and nitrogen, and all these values should be less than 10. So this is the international parameter, that the anion gap should be less than 12 and the osmol gap should be less than 10. So then comes the radiographic analysis. In laboratory, you can make these simple biochemical tests on sodium, glucose, and others. And then next comes the radiographic analysis. Radiographic analysis is helpful if the patient has taken some elements, say for example copper, or say for example lead. Even if the carbon tetrachloride has been ingested, so the abdomen will give some opaque pictures, opaque photographs or x-rays will be obtained, and by that you will be able to know that actually the patient has consumed or pesticide, polyaromatic hydrocarbons. If they had been pesticide, then the abdominal x-ray, pulmonary x-ray, the x-ray of the lungs, and the CT scan. CT scan is nowadays used very frequently, and the doctor, by performing CT scan, can tell if there is something that has reached to the brain, whether brain has been affected or not, because there are many neurotoxins. So there is a category of toxins: barbiturates, dyes, pesticides, sulfas, organophosphate compounds, chlorpromazine, strychnine, gentamicin, and these opioids, and these what you call them, the barbiturates, the tranquilizers, the sleeping pills, very easily available and one consumed. Even the acetaminophen, paracetamol, high doses of paracetamol. So these are some of the common drugs which are easily available, especially in India, and they are consumed by the person who is not happy with his life, wants to commit a suicide or wants to die, and then taken. In accidental poisonings, the case is totally different. Then after this diagnosis, when it has been diagnosed that the patient suffers from such a problem, we move to another issue, and that issue is of prevention of absorption. This is the next element of clinical toxicology: prevention of absorption. Already absorption has happened, and how we can prevent further absorption. For that, there are certain methods, and one very frequently method is emesis. A tube is put in the oral cavity, and the glucose or water is allowed to enter into the stomach, and the person vomits. So after vomiting, the poison comes out. So emesis is a frequently used method. The second method is washing of the stomach. That is technically it is called as lavage. The stomach is washed with the saline water or with some another. Then the skin wash. Say for example, if some gas or some such poisoning has occurred, the skin is to be washed. Even the clothes are to be washed. Skin, clothes, everything is to be washed. And then there is another one. If it is established that the poison nature of the poisoning in so and so, then activated charcoal. I had been telling you about the activated charcoal. It has got a very strong adsorptive capacity. Whatever is there, the activated charcoal molecules will absorb it and will prevent further absorption, because it will be absorbed by the activated charcoal, and activated charcoal will be removed through feces. So activated charcoal is another one. And then there is one more suitable method. We call it aspiration, aspirates. And the next element in this clinical toxicology is the enhancement of elimination. How we can accelerate the process of elimination of the poison. Poison is there, but how we can accelerate the elimination. And for that, the patient is put on dialysis. Dialysis, it is used to remove ammonia, urea, and other harmful waste which are produced in the body after metabolism. And if the kidney is not performing well, then a patient is suggested dialysis. And in dialysis, there are certain other methods. These methods are hemodialysis, plasma dialysis. The entire plasma is removed and a frozen plasma is again put into it, because many things, they have been absorbed by the proteins of the plasma, and they are irreversibly bound to the proteins of the plasma. So how we can remove those proteins? We cannot. So the entire plasma is removed, and that is called as plasma dialysis or plasma exchange. There is one dialysis common, then there is hemodialysis, the blood is removed, the plasma is removed, and hemoperfusion. These are some of the methods which are used to accelerate the process of the elimination of the toxin from the body. The next is the use of antidotes. Antidotes are those drugs which will be helpful in eliminating the poison. Say, for example, lead or copper or mercury has been ingested by somebody to kill himself. The chelating agents are the best choice. D-penicillamine, EDTA. These British anti-lewisite, it was used in the Second World War to remove the toxins from the body. BAL, we in short we call it as BAL, British anti-lewisite. These are some of the chelating agents. Their function is to irreversibly bind with the molecule and remove it from the body. It cannot escape from the chelating agent once it has chelated. Then we have got certain very good drugs like atropine sulfate. It is given to all those patients who have consumed these pesticides, chlorinated or phosphate compounds. carbamates. Atropine is the panacea for them. Atropine does very well. Then we have got, of course, activated charcoal. And sometimes sodium nitrite is given. Actually, sodium nitrite is poisonous because it induces the synthesis of the methemoglobin. But methemoglobin is used to combine the hydrogen cyanide or the cyanide compounds which are present in the blood. They will now join with the methemoglobin, and the cyanide will be removed. So in this way, the sodium nitrite has also been used as an antidote. These are the when the patient has been stabilized, the elimination has been performed, the absorption has been stopped, then these treatments are given. And after that, we have got some uh, after that we are to support the patient. And now the patient is okay, but the patient is to be supported. So the support comes from the psychologist, psychiatrist, if we specifically if we use the term, it is the psychiatry, that he will talk to the patient, will try to stabilize the patient psychologically, that whatever has been done was a temporary phase, now you should forget about that, you have been treated well and there is no problem, like this, so on, so on, so on. A psychiatrist will be very much helpful in stabilizing the patient. These are the supports. So these are some of the basic methods or basic components of this particular subject of clinical toxicology. Clinical toxicology. There is a very good book written by Goldfrank. Goldfrank. This is the toxicologic emergencies. Goldfrank Toxicologic Emergencies. The title of the book is like this: Goldfrank Toxicologic Emergencies. It has been written by a scientist. The name is Goldfrank. It is not there in our library. You may not find it, but maybe you may find it on the internet, and you can go through it. Go through it, and you can get the necessary information. So these are some of the issues that are related with clinical toxicology. I hope they will be helpful to you. They are just the tips to start with this particular subject. Even Kesseret and Doll gives a separate chapter on clinical toxicology. You can go to that particular book. In my book, you won't find clinical toxicology. So stay home, study well, keep safe. We shall meet again sometime later. Thank you for watching.